we will start again the second part of this lecture, which contains the findings in lung disease. The high resolution findings of lung disease could be categorized or classified into four major groups: linear, nodular, increased density, and decreased. Let us start with the first one, linear or pattern. Under this heading, we have about 6 subtypes. The first is interlobular septal thickening, peribronchial or peribronchovascular interstitial thickening, honeycombing, subpleural line, intralobular linear opacities, and the sixth one is a recently described pattern which is called perilobular. Number 1, interlobular septal thickening. When we see more than few interlobular septi, this means that the patient is not normal. He has septal thickening. When we see septal thickening or interlobular septal thickening, we should classify them or subclassify them into smooth, nodular or beaded, and irregular. And as you see, the differential diagnosis of each subtype is a list like this. Okay, so we can describe the septal thickening as a smooth one. This is most common seen in pulmonary edema, lymphangitis carcinomatosis, nodular or beaded in lymphangitis carcinomatosis, lymphoma, sarcoidosis, silicosis, or irregular, which is a sign of lung fibrosis seen in interstitial fibrosis and associated with a distortion of the lung architecture. Let us see. As you see, lines perpendicular on the pleural surface, the length is from 1 to 4 centimeters, and here, as you see, it is smooth. This is a smooth thickening of the interlobular septum. Here, the map reconstruction is very helpful because it augments the septal thickening, and you can see it as polygonal pattern of density. And also it is important because if we see with septal thickening dilated pulmonary veins, we can diagnose the presence of pulmonary edema due to heart failure. Look for this. Septal thickening, they are perpendicular on the pleural surface, but as you see, they are nodular or beaded. We can see this in lymphangitis carcinomatosis and in sarcoidosis. Here and there are pleural septal thickening, but as you see, they are not linear, they are irregular in shape, and this is a sign of lung fibrosis. The second type of linear opacities is peribronchial or perivascular interstitial thickening. As I have told you, thickening of the peribronchovascular interstitium, which is equal to peribronchial cuffing or thickening of the bronchial walls, is seen by irregularities and thickening and ill definition of the walls of the arteries and the bronchi. The third one is the thickened subpleural interstitium. As you know, the interlobular septi contains the same histological structures like the subpleural interstitium. So, they have the same differential diagnosis. Thickening of the fissure can present as subpleural or subpleural interstitial thickening. If the thickening is smooth, it may be difficult to be differentiated from fissural fluid if the thickening is irregular or nodular in appearance and interstitial abnormality is more easily diagnosed. In general, the differential diagnosis of subpleural interstitial thickening is the same as that of interlobular thickening. In the previous part of this lecture, we told you that normal fissure should be less than 1 millimeter thickness, smooth, well-defined, and as you see, regular in shape. We use the fissure because this is the area we can comment on the pleura, but in some cases we can see the pleura in this extended window view. It has the same differential diagnosis. It could be irregular like this, it could be beaded, irregular, denoting that we have distortion of the lung parenchyma, and this is a very important term, honeycombing. Pathologically, honeycombing is defined by the presence of small cystic spaces, generally lined by bronchial epithelium and having thickened walls composed of dense fibrous tissue. When we write the word honeycombing in our report, it means that this is an end-stage lung and can be seen in almost any process leading to pulmonary fibrosis. Honeycombing produces a cystic appearance on high-resolution CT, which is easily recognized and allows a confident diagnosis of lung. As you see, this is honeycombing. But what are the criteria that can allow me to tell that these cystic spaces are honeycombing and nothing else? They average in size from 1 centimeter or above. Okay? They have walls ranging in 1 to 3 millimeter in thickness. And as you see, each cyst share wall with the nearby cyst. They share walls. There is no normal lung in between these cysts. This is very important. Bronchiectasis or traction bronchiectasis is another sign of lung fibrosis. As I have told you, there are some sure signs that can tell us that we have lung fibrosis, including honeycombing, including irregular septal thickening and irregular fissures, and in addition, traction bronchiectasis. What happens? When there is fibrosis surrounding the bronchi, it pulls on the wall of the bronchi, producing a corkscrew-like dilatation of the bronchi, denoting what is called traction bronchiectasis. And on the level of the bronchioles, it is called traction bronchiolectasis. This is another sign of lung. Here an MANEP can easily make sure diagnosis that we have traction bronchiectasis or even traction bronchiolectasis. This is the normal thin cuts. You cannot tell if this appearance is due to presence of honeycombing and tiny cystic structures, or it is due to fibrosis causing traction bronchiectasis. So MANEP is very important in this issue to tell that we have this or traction bronchiolectasis. Sorry. Another pattern of linear or reticular group, what is called perilobular thickening, like this. It is thickening of the perilobular septi, including the interlobular septum and so on. And this one was described in a specific condition called organizing pneumonia. We will speak about it in the next lecture, inshallah. And this is how we can see it. Perilobular septal thickening or perilobular pattern of linear thickening. The last or the fifth subcategory is intralobular interstitial thickening. It is seen as a fine reticular pattern giving what is called spider web or lace-like appearance. Bizarre shape, very thin lines that you cannot tell whether it is interlobular septal or perilobular thickening. It is more or less bizarre shape, and it is one of the signs of lung fibrosis similar to honeycombing and traction or bronchiectasis. Let us review the different reticular pattern. This is the interlobular septal thickening. This is the perilobular pattern. This is the lace-like or spiderweb-like intralobular septal thickening. And these are the corresponding high-resolution appearance. Again, let us summarize. High-resolution findings of fibrosis. This is what? Honeycombing. This, traction bronchiectasis. And what is this? This is intralobular septal thickening. Intralobular septal thickening. And herein we have distortion of the lung parenchyma in addition to intralobular septal thickening. The last one in the reticular group is the subpleural line. It is an irregular line that parallels the pleural surface and may be seen in patients with subpleural honeycombing. Few millimeter in thickness, less than 1 centimeter from the pleural surface, and parallels to the pleura. This is what we call subpleural line. It is also what we call subpleural line. Particularly, this can be seen also in some normal persons as a result of atelectasis in the dependent lung, posterior lung surface, when the patient is supine. Such normal lines are transient and disappear in prone position if you are not sure that it is physiologic. The second major group is the nodules or nodular lesions. Herein, we are interested in the small and micronodules, while larger nodules, we will speak about them in the third lecture, which is about the solitary pulmonary nodule. Small nodules and large nodules, we are concerning today about small. If you wanted to describe small nodules, we have different items to comment: size, appearance, is it well defined, interstitial, meaning that it is in the interstitium, or ill defined in the air spaces, its attenuation, soft tissue, ground glass nodules, or calcified nodules. But the distribution of nodules shown on high resolution CT is the most important single factor in making an accurate diagnosis regarding the cause of these small nodules. We have three types of distribution called perilymphatic, random, and centrilobular. Let's go. How we can describe a nodule according to its type or its distribution. What we should do? They said, number one, go to the pleural surface. Look, if the nodules are touching the pleural surface, like this and like this, these will be called or can be called either random or perilymphatic, touching the pleural surface. How to differentiate random from perilymphatic? The perilymphatic nodules are running along the septi, interlobular septi, the subpleural interstitium, and along the peribronchovascular interstitium. If you see the nodules having this distribution, call them perilymphatic nodules. But if the nodules are touching the pleura, but not biased to these anatomical structures, randomly distributed, you can call them random. Now, again look to the pleural surface. If the nodules are away from the pleural surface by 1 to ½ centimeter, it means that it is affecting the centrilobular area of the secondary pulmonary lobule. Herein, you will call them centrilobular nodules. Let's make this exercise. Look for these nodules. Oh, they are touching the pleural surface. Number 1, so it is either random or perilymphatic, but they are running along the fissure, along the peribronchovascular interstitium, so these are perilymphatic nodules. Let us see this. The nodules are touching the pleural surface. It could be random or perilymphatic, but they are randomly distributed and not biased by the peribronchovascular interstitium or interlobular septi and so on. So these are random distribution. Now look for these. Most of the nodules are away from the pleural surface. This is the fissure, nicely seen. But the nodules are away from this fissure. It means that we have centrilobular nodules. Again, if you have pleural nodules, that means it is touching the pleural surface. Biased by the subpleural, septal, and peribronchovascular, this is perilymphatic distribution. The most common differential diagnosis of perilymphatic distribution is sarcoidosis, silicosis, and lymphangitis carcinomatosis. If they are not like this, randomly distributed, we will call them random distribution, and if we mention that it is random, it could be miliary infection, such as TB or fungal, or metastasis. If the nodules are centrilobular in distribution, herein we have another subclassification for centrilobular distribution. First, I want to apply this to actual images. As you see, these are perilymphatic nodules. This is again different loads and shapes of perilymphatic nodules. These are random nodules. Okay, can be heavy like this, few like this, and so on. Regarding centrilobular nodules, it could be of ground glass nature. It means that it is ill-defined and not that dense. It could be nodules or rosette-like this. It is more dense, definitely, more well-defined and hyperdense nodules. Okay, sometimes the bronchiole inside these nodules may be still having air, giving this appearance of cavitation. And this one is very important. It is called tree-in-bud nodule. We can see it as if it is a branching structure with buds on its terminals, like this. In MIP image, look, you can see as if there is a tree with some buds on its terminals. This is very important in our reporting that we have tree-in-bud nodules. This is the actual tree-in-bud nodules and from where the names comes. And the MIP, I have told you, is very important to these. Again, this is the example of MIP. maybe at 3 millimeter, we can start to see nodules, and here we see definite 3 impad. Again, let us summarize. If we have centrilobular nodules, we should answer the question, is there 3 impad or 3 impad is absent? If there is 3 impad, it means that it is a bronchiole disease. What does this mean? Either pus or rarely tumor cells can produce bronchiolar dilatation and stagnation, giving the 3 impad. If 3 impad is not present, this means that we have either disease due to small airway disease or small vessel disease, such as hypersensitivity pneumonitis or vasculitis and so on. And this is the differential diagnosis of 3 impad or absent 3 impad nodules. Okay, let's go to the third group of increased density. The third group, increased. Two subdivisions, either consolidation or ground glass opacity. You will hear a lot about ground glass opacity, especially in our crisis now in Egypt and the whole world regarding the new coronavirus. What is the difference? Consolidation is an opacity that you cannot see pulmonary vessels through them, while in ground glass opacity, less increased density or hazy increase in lung opacity, but you can see the vessels through this opacity. Okay? Ground glass opacity, just faint increased density. You can see the vessel through it, or sometimes you can see the bronchus through it, which is called dark bronchus sign. While consolidation, you don't see vessel, but you may see the air in a bronchus, which is called air bronchogram, but take care. This bronchus may be obliterated by fluid or cells or something in addition to the consolidation, and you may not see air bronchogram. Again, if you see vessels through the opacity, this is ground glass. If you don't see vessels through the opacity, this is consolidation. In both, you can see dark bronchus sign or air bronchogram according to each. Let's apply this. What is your opinion about this opacity? It is faint or hazy, and I can see vessels running through them. This is ground glass opacity. But what about this? Oh, I cannot discriminate vessels running in this opacity. This is consolidation. And sometimes you can see air in the bronchus. This is called air bronchogram. But if you don't see air bronchogram, this doesn't mean that it is not a consolidation. As you know from pathology, consolidation is the replacement of the air spaces either by blood, edema, pus, tumor cells, or even fibrosis. If another pattern is also present, such as small nodules, the consolidation mostly represent confluent disease and should be ignored for the purpose of differential diagnosis. So when we find consolidation in addition to nodules, try to explain the type of these nodules. It can help more than. Again, this is consolidation. I cannot see vessels, and it has air bronchogram. This one is also consolidation, but without air bronchogram. Ground glass opacities. This is a great dilemma in the CT chest. It is filling, it could be either filling of the alveolar spaces by pus, edema, hemorrhage, inflammatory cells, tumor cells, representing airspace disease. Or it could represent thickening of the interstitial or alveolar walls below the spatial resolution of high resolution CT, representing interstitial lung disease. So ground glass can be seen in airspace diseases and in interstitial lung disease. I want to give you some tips. Can you look to this lung and this? It looks as if there are ground glass opacities. Am I right? Easy opacities, and I can see vessels through them. This patient was repeated. There is disappearance of the ground glass opacities. What has happened? Look for the trachea here and trachea here. The trachea here is collapsed and the posterior membranous wall is projecting into the lumen. This is expiratory film or expiratory CT scan, and this is the inspiratory. So don't say that the patient have ground glass opacities if you see the trachea like this. This is just expiratory film. To tell that we have ground glass opacity, the patient should have a rounded trachea like this, having adequate inspiratory effort. Our rule as radiologists is to answer a question to the clinician. As I have explained to you, ground glass opacity could be due to inflammation, just viral pneumonitis, or it could represent interstitial lung fibrosis. So you should look for the other signs of fibrosis if they are present, such as we have here. Yes, this is honeycombing. This is traction bronchiectasis also in addition. These are signs of lung fibrosis. So the ground glass here is part of the interstitial fibrosis. But if you don't see other signs of fibrosis, this may represent a case of what is called cellular or inflammatory ground glass opacities, and this is more favorable and can be treated. But the ground glass opacity in cases of lung fibrosis are called fibrosing ground glass opacities, such as in fibrosing non-specific interstitial pneumonitis. Because we are in the area of ground glass, there are many descriptions and signs related to the word ground glass opacity. One of them is called the mosaic attenuation. What is meant by mosaic attenuation? It means that you see part of the lung is dark and the part of the lung is more or less increased density of ground glass, giving mosaic pattern. And this is a great dilemma because we don't know which is the abnormal and which is the normal. Sometimes the mosaic attenuation results from areas of ground glass opacities which appears bright and normal lung which appears dark. This usually means that we have infiltrations by inflammatory cells, by tumor cells, and so on. The second scenario, that we have areas of air trapping appears dark, and the normal lung appears by illusion to be bright. This in small airway disease due to air trapping. Sometimes, in cases of chronic thromboembolism, the area that has been exposed to thrombosed pulmonary arteries become hypoperfused, and on CT it appears more darker than the areas hyperperfused or the normal lung. This is called mosaic perfusion. The big term is called mosaic attenuation. But if this mosaic attenuation is due to chronic thromboembolism, we can use the term mosaic perfusion. But it is correct for you to tell that we have mosaic attenuation of the lung. So we have three scenarios. How to differentiate? Okay? There is a trial. It may help you, or sometimes you cannot differentiate. What is it? The first rule, look for the areas of increased density and the areas of normal or hypo or decreased densities. If the vessels inside both are equal in size and in number, this will mean that there is ground glass opacity in this area due to infiltration. Here an map is helpful. Make the map to see the vessels clearly. If the vessels in the bright and dark areas are equal in size and in number, this means that this is an area of ground glass opacities. Number 2, again, let us make the same exercise. This is an area of low density or dark, and this is an area of increased density. If the vessels in the dark area are sparse, smaller, and less in number compared to this area, it will mean that this black area is the pathological one. It could be due to air trapping, small airway disease, or due to chronic thromboembolism due to hypoperfusion and hyperperfusion. Here and we go to do pulmonary angiography to look for signs of chronic thromboembolism and so on. Okay? I have mentioned to you the word air trapping. Air trapping is a sign due to obstruction of the airways that during expiration the lung doesn't collapse. Sometimes, and some people have totally normal CT chest, but they have areas of air trapping. How we can see these areas? We can do expiratory. Look for this patient. Look for this area of air trapping. It is blackish like this. And this area contains ground glass. If we go to do expiratory film, please compare. The area of air trapping doesn't collapse during expiration. But the normal lung, or the lung even containing ground glass opacity, will collapse in size and show increased density. So expiratory film sometimes is very important to detect areas of, or to confirm areas of air trapping. By the way, presence of area of air trapping, ground glass opacities, and fibrosis are called a sign called head cheese sign. Head cheese sign, simulating this appearance. Areas of air trapping, areas of consolidation or ground glass opacities together in the same column. Head cheese sign. It has been described in chronic hypersensitivity pneumonitis. Another sign which use ground glass inside it, something called crazy paving. What is crazy paving? Crazy paving is constituted of areas of ground glass opacities and interlobular septal thickening. Okay? Combination of both septal thickening and ground glass opacities. Can be heavy like this, moderate like this, or sporadic like this. The first time crazy paving was described in a pathology called bronchoalveolar proteinosis, okay, or alveolar proteinosis. But actually, this is not specific only for this pathology. It can be seen in infections such as coronavirus. It can be seen in lymphangitis carcinomatosis. It can be seen in bronchoalveolar carcinomatosis, carcinoma as well. Okay, this is what is called crazy sign. Another sign in where ground glass is seen called atoll sign. What is meant by atoll sign? It is, as you see, some types of islands containing water inside. You can see from the aeroplanes, and the corresponding is a core of ground glass opacity surrounded by a crescent or ring shape, total ring shape of increased density. This is called atoll sign. The first time described this sign was in cryptogenic organizing pneumonia, but again, it is not that specific. It can be seen in many diseases, including coronavirus. The reverse. If you see opacity surrounded by ground glass attenuation, solid lesion or consolidation surrounded by a rend or a rim of or a halo of ground glass. This is called halo sign. The previous one can be also called, the atoll sign can be called reversed halo sign. If we see this appearance, it means that either we have a fungal infection with fungal infiltrations or hemorrhage, or a tumor with peritumoral infiltrations or hemorrhage. Okay, so this is halo. Again, this is halo sign. The core is hyperdense with a rim. And this is the reversed halo sign, or what is called atoll sign. Okay, atoll sign. This is the fourth and last group, the group of decreased density. Decreased density can be geographic, such as emphysema, mosaic perfusion, air trapping, or well circumscribed, such as in cysts, emphysema, and bronchiectasis. This diagram summarizes the different types of decreased densities. Let us start with cysts. As a definition, cysts, and cyst, of course, in the lung, we mean air cysts, okay? It is a thin, usually less than 30 millimeter walled, well-defined, and circumscribed air-containing lesion. On the other hand, cavity is defined as radiolucent or airspace with a wall thickness more than 3 millimeters. So the thickness of the wall differentiates cysts from cavities. This is the differential diagnosis of cysts. It can be seen in lymphangioliomatosis, histiocytosis, papillomatosis, Sjogren syndrome, nematoceles, and so on. Cysts are isolated and don't share walls. Do you remember honeycombing? Honeycombing do what? Share walls. And usually are unassociated with other signs of lung fibrosis. Look for this. These are cyst sharing walls. This is honeycombing. But here, as you see, the cysts are separated by normal lung in between. Sometimes they may be bizarre and irregular in shape, but the intervening lung parenchyma appears normal and there is no evidence of fibrosis. This pattern of bizarre or irregular thickening of the wall can be seen in Langerhans cell disease. Sometimes these cysts are located at the periphery of the lung and may rupture into the pleural space, presenting with spontaneous pneumothorax. Let us go to emphysema. Emphysema is subdivided into three types. The first one is called centrilobular emphysema. Centrilobular emphysema results in focal lucences without walls to differentiate them from cysts, and has a dark spot or a bright spot in its center called central dot sign. Look for this. This represents the arteriole in the core of the secondary pulmonary lobule, and we use this central dot sign to differentiate it from lung cysts. So, centrilobular emphysema is ill-defined, increased area of lucency containing a dot in its center, okay, and distributed all through the lung. These are the mimics of cysts. Number one, cavity. As I've told you, cavity has a wall thickness more than 3 mm. Bronchiectasis, and we will describe them in the coming few slides. Bronchiectasis are more or less elongated, having continuity with each other. They can be connected and having a sign called signet ring sign, like this. I will describe it shortly. And the last thing is centrilobular emphysema, and as you see, we use the central dot sign like this to differentiate cyst from centrilobular emphysema. This is very clear. The dot is in the center, representing the arteriole. This is centrilobular emphysema, while the arteriole is at the periphery here in cases of cysts and bronchiectasis. Okay, this is another explanation. Panlobular emphysema. The lung as a whole or a loop is being too lucent and contains a few vessels. Focal lucences, as would be seen in centrilobular or bullous emphysema, is not visible. What actually occurs? The lung enlarges and the vessels become away from each other, and you don't see focal areas of lucency. The whole lung is lucent. This is what is called panlobular emphysema. We can see this in congenital cases as congenital lobar emphysema, and if we have also a foreign body obstructing the artery, obstructing the bronchus, acting as a valve, we can see panlobular emphysema. The third type of emphysema is called paraseptal emphysema. It represents as multiple cysts at the periphery of the lung, okay, marginated by the interlobular septum, and these can be the source of large lung polyp. Okay, we can see them in normal persons, and more commonly we can see this paraseptal emphysema in patients who are smokers, in addition to the centrilobular type. Okay, this is paraseptal emphysema, and this is honeycombing. How we can differentiate both having the same appearance? Paraseptal emphysema, one row only. Honeycombing usually presents as multiple rows. In addition, there is no signs of lung fibrosis, but here we can see other signs of lung fibrosis such as traction bronchiectasis, distortion of the lung parenchyma, and so on. So it is very important to differentiate paraseptal emphysema from honeycombing. As I've told you, if you mention honeycombing in your report, this is very serious. Paraseptal emphysema, some of them may enlarge to make large bulli like this. Bronchiectasis. Bronchiectasis morphologically can be classified into cylindrical, varicose, or cystic, according to its. Normal bronchi usually taper as we go to the periphery. They are not running parallel. But if we have parallel walls with lack of tapering, this means that we have cylindrical bronchiectasis. And in this condition, we apply our rule. If you see that the bronchus diameter is larger than the nearby artery, we have bronchiectasis. And this gives the very nice appearance of signet ring sign. This is signet ring sign. We use it to diagnose bronchiectasis. If the walls are varicose like this or corkscrew like this, it is varicose type of bronchiectasis, and it gives the appearance like this. You see the ball is irregular. Okay, this is varicose type of bronchiectasis, and if this is more exaggerated to give saccular or cystic appearance, we can see them as multiple cysts giving grape-like appearance, and sometimes these cysts contains air fluid level, and in this condition we can diagnose with bronchiectasis. To diagnose bronchiectasis by all its types, we have direct signs such as signet ring sign, lack of airway tapering, presence of dilated bronchi at the outer third or outer fourth, or presence of mosaic attenuation due to large airway disease with areas of air trap. Of course, we can use signet ring sign to differentiate bronchiectasis from just lung cyst, but sometimes we can fail to use this sign alone to differentiate. This is another sign which is called tram track sign due to bridging mucosa between the parallel walls of this. The other indirect signs include bronchial wall thickening, mucoid or mucus impaction inside the bronchi, and tree-impulse nodules in association to bronchiectasis, because tree-impulse nodules means that we have endobronchial spread of infection distally into the bronchiole. Also, from the other signs, mosaic attenuation due to air trapping, bronchial artery hyperplasia, and of course, NPR is important to show the continuation or the connection between the lumina of multiple cysts, such as in this axial image. It means that it is a tubular structure. But if we do MENEP, we can see that these are representative of either honeycombing or bronchiectasis or bronchiole ectasis. A very important sign that you should know. As I've told you, each bronchus is paralleling an artery. You see bronchus and nearby touching artery. If you see two bright rounded structures beside each other and you don't see air-filled bronchus, this means that this bronchus is filled with fluid or mucus or blood, and this is used to diagnose the patients with allergic bronchopulmonary aspergillosis. The lumina are filled with mucus and there is mild central bronchiectasis. Let's go to the last part of our lecture, basic interpretation. You have to reach a diagnosis, or at least to reach a narrow list of differential diagnoses. So you should answer 4 questions while analyzing the high resolution. Number 1, what is the dominant pattern? Is it linear, nodular, increased opacity, or decreased lung opacity? And which is the predominant subtype in each category? Okay, because each one of these has a list of differential diagnosis. The second question, where is the pathology? Is it in the centrilobular area? Okay, or is it random in cases of nodules, or lymphatic distribution? The third question, where is the dominance? Do we have upper dominance rather than lower zone of the lung dominance? Or we have central dominance versus peripheral dominance? Because as you see, each has its own differential diagnosis lists. There is the fourth question. I'm sorry that the slides have jumped. The fourth question, is there additional findings or not? What are the additional findings? Do you have pleural effusion? Do you have mediastinal or hilar lymphadenopathy? Do you have something in the bone? Do you have something in the upper abdomen? These are very important to answer. By answering these 4 questions, you narrow the differential diagnosis list. Many diseases, in spite of this, have similar patterns of high resolution on HRCT. For example, ground glass opacity. All these 4 patients have ground glass opacities. If the patient is a smoker, we can think of respiratory bronchiolitis. If the patient is immunocompromised, we can think of pneumocystis carinii pneumonia. If the patient is coughing blood, this ground glass could represent pulmonary hemorrhage. If the patient is a bird breeder, we can think of hypersensitivity pneumonitis. So clinical data are very important to reach a diagnosis and to narrow the differential diagnosis of these similarities in high resolution CT. I know that these findings, or what I have explained in the previous part of the lecture and in the current part of the lecture, are very difficult. I know that. But if you concentrate and repeat the listening and the reading the slides carefully for several times, you will build your basics in reading CT of the chest. This is very important, and actually we use all these terms in our reporting, and in the coming lecture you will find how important to know these basics regarding the anatomy and the abnormality patterns to reach a diagnosis in many of the diseases that we can see every day. I would like to thank you, and I hope that you will benefit from these lectures. Thank you very much.